Sesim geliyor mu hocam?
Evet, geliyor.
Merhabalar.
Merhaba.
Ercüment hocamın yerine siz herhalde sunum yapacaksınız.
Evet, doğru. Koray Yalçın'dan. Hocam.
Memnun oldum hocam, Kenan Demir.
Ben de çok memnun oldum.
Bahar hocam merhabalar.
Kenancığım nasılsınız? Koray hocam hoş geldiniz.
Hoş bulduk hocam. Nasılsınız?
Teşekkürler. Sunumunuzu büyük merakla dinleyeceğiz. Çok güzel de bir şey var, katılım var. Kongremize merakla bekleniyor. Sanırım küçük bir video hazırlanıyor şu sırada sizin oturumunuzdan önce. Onunla ilgili bir hazırlık var. Birazcık belki bekletme imkanınız varsa sizin.
Tabii hocam, hiç sorun değil.
Yoksa.
Hocam bu arada bir şey sorabilir miyim? Ercüment Hoca'nın bana bildirdiği ve hazırladığımız sunumda bizim kendi tedavilerimiz ve hücresel tedaviler ve gen tedavilerinin geleceği. Doğru değil mi? Yani
Doğru.
Tamam, Covid'le ilgili bölüm var sonunda ama tamamen Covid'le ilgili değil sunum.
Evet.
Tamam,
Evet,
tamam,
evet.
Tamam.
Sanırım videoyu hazırlamışlar. Sizi bekletmemek adına sizin sunumunuzdan sonra şey yapacaklarmış. Kongre saati, timingi bozmamak adına sizin sunumlarınızdan sonra tanıtım videolarını döndüreceklermiş.
Tamam hocam.
Sayın moderatörüm, size bırakıyorum session'ı.
Merhabalar. Hocam hoş geldiniz.
Hoş bulduk.
Ahmet hocam siz de hoş geldiniz. Başladık herhalde.
Başlayalım mı? Ben ekran paylaşımı
Ben size yetki verdim ekran paylaşımı için.
Tamam, başlıyorum. Evet, ekran görülüyor mu?
Evet hocam.
Tamam, başlıyorum o zaman. Öncelikle düzenleme komitesine bu nazik davetleri için teşekkür ederek başlamak istiyorum. Bugün benim
Committee for their kind invitations. Together, I'm going to talk about the future of cell and gene therapies in medicine. Of course, before starting to talk about the future, maybe we should start from the past. The picture that you see here is unfortunately one of the most catastrophic moments of the world. This is the atom bomb.
Tarihsel gelişim açısından önemli bir fotoğraf aynı zamanda. Çünkü hepimizin bildiği gibi.
And as we all know, these cellular treatments are actually applied for the first time in the world when this atom bomb was thrown.
Yaygın olarak literatüre girdi.
And then it was widely a part of the literature and it was seen as a part of a treatment option. And after that, as a pediatrician, I think this slide is very important because for treatment purposes, we also started to do a big bombardment to our bodies. Unfortunately, in the treatment of many cancer, mainly leukemia, we're using plenty of bombs. This is a very dramatic slide, which indicates how things can affect the pediatric patient. Chemotherapy drugs can have a bad influence on many of the organs of the body. It's like an atom bomb that is thrown on the body of a pediatric patient. Of course, we're fighting leukemia, but it has its costs. Of course, chemotherapies are not things which should be underestimated because in the treatment of cancer, what brings us to today's survival frequencies is those chemotherapies. I think this is a very important graph. In 1960, survival rate was 10%, but in the 21st century, just by chemotherapy, things have changed. I have to say that in standard risk, that is low risk leukemia, the survival rate has even reached 91% in pediatric patients. Although this is giving harm to the cell and has an atom bomb effect, this success belongs to the success of the chemotherapies. But if we're going to talk about the success of medicine, we shouldn't forget that this travel from the past has to be discontinued at some point, because we have reached a higher level in treatment. In the cancer treatment, non-targeted things are not necessary anymore, because the targets should be known. The cells which shall be destroyed should be known in advance. As you know, CAR T cell treatments are very much popular these days. CAR T cells are actually things which mean T cells being ruled out and the continuous receptor synthesis taking place. So a targeted cellular therapy is what we're talking about here. Therefore, in a targeted manner, the tumor cell, the cancer cell is being found specifically. So thanks to those CAR T cell treatments, new success graphs are appearing in front of us. On the left-hand side, you see CAR T cell treatments, largest patient series of that period, and it's a survival graft. In the survival graft, we see that the rate is 78%. You may think that it's low, but in a standard, but this is not in a standard risk patient, but in a leukemia patient, which was not responding to any treatment, then therefore it is a very revolutionary development, to be fair. And in Turkey, in Acıbadem Hospital, our own academic CAR T cells are being produced. FDL-approved CAR T cells are being commercially used in the world. In 2017, the first approval was given. In 2020, we issued an article, and the academic CAR T cell that we produced was found to be efficacious. And recently, the patient results, outcomes will be published. In terms of cellular therapies, there is another method, and these are natural killer cell treatments. This is the best picture, which indicates the natural killer cells. A tumor tissue and the infusion of NK cells is indicated here. It looks like a starry night. It is very effective, in my opinion. And the starry night is destroying the tumor, which is shown with dark blue, and it indicates how the NK cells are working here. Of course, with our own experience, we can see the same thing. NK92 cellular therapy for pediatric relapsed and refractory Ewing sarcoma was used for the first time like this. Chemotherapy and radiotherapy was not responded by those patients, but now we see that things are changing. In the future of chemotherapy, we see that this is going to be a very important role. In cellular treatments, things are important, but I'd like to talk about some other treatments as well, like gene therapy. Gene therapies are on the agenda of medicine for a very long time, especially for orphan diseases. Gene therapies are being used frequently. This is a very striking graph. In 1983, FDA has approved only 2 gene therapies, but in 2017, within 1 year, 77 different products were approved. This is an incredible increase, and it shows that there is great interest in the area. But gene therapies are gradually becoming more and more individualized. Now, person-specific gene therapies have been initiated. Mila Mokovic's story is very striking at this point. The name of the drug is Milasen, since it was produced specifically for that person. Mila Mokovic was a person who had a neurodegenerative disease called Barton disease, and there was no treatment until then for that disease. But Milasen applied to the Children's Hospital in Boston, Boston's Children's Hospital. The gene disorder was treated by oligonucleotides treatment, exon 6 and exon 7. Between those two, in NF8 gene, there is a stopper codon, and when this treatment is used, the disease was becoming better. It was improving. Functional tests on the cellular basis have also proven that this was possible. This neurodegeneration was disappearing as a result of this. Recently, in the Journal of Medicine, this was issued as an article, and it was published as a patient-specific treatment. Diagnosis was made in 10 months. The gene was designed in 10 months, and the drug was approved by FDA, and it started to be used for that specific patient. Of course, what is important for us is CRISPR technology as well. Thanks to CRISPR technology, again, individualized therapies are now in question. Again, people who have orphan diseases can be provided with such specific designs. Cardiac diseases are very frequent, and the heart disease vaccine is what we're talking about here. To control LDL, TC8K9 enzyme is being inhibited by CRISPR technology. This is a great success, and also for Duchenne muscular dystrophy, the same method is being used for the same purpose. TCR and TCR alpha penicillin is affecting the PD-1 receptor, and they're all being ruled out, and a specific antigen is being loaded. Therefore, a very strong T cell can be obtained in the treatment of refractory cancer diseases. I will go back again. In cellular treatments after bone marrow transplantation, what we're using the most and what is dating back to the past is mesenchymal stem cell treatment. Here you see the concoccal microscopy image, a colorful image of the stem cells. This is an old friend, but it can be used for a new enemy today, and it's going to have a place in the future of medicine. Mesenchymal stem cells are really important. In the cytokine storm created by COVID-19, mesenchymal stem cells are being frequently used during the pandemic. Two phase 1 studies from China are showing that the umbilical originated mesenchymal stem cells can stop the disease. Again, in our own laboratory, we're producing mesenchymal stem cells, and with a multi-centered use in critical COVID-19 patients, we can obtain certain improvements, and we got really positive results as a result of this. Towards the end, I would like to thank you on behalf of my team for giving us the opportunity, and Ercüment Ovalı is sending you his best regards. He very much wanted to be present, but unfortunately he's very busy and could not make it here. I tried to make the presentation instead of him. If you have any questions, you're more than welcome to ask them. Thank you very much. Thank you very much. It was a perfect presentation. How could you clearly deliver such complicated messages to us? We're closely following your success. We would like to wish all the best to Ercüment Bey and his team. We've been following you up close. In this presentation, there is something which I find very interesting. You're a hematologist and also an oncologist, and T-cell treatments together with gene therapies are being used in a combined manner in your studies, and you're showing us that this actually is a teamwork, and interdepartment communication is required. Well, unfortunately, there is no sound. Is it because of me or it's because of the connection, Bahar Adam's connection? Okay, I see. I think she is disconnected, so let me continue thanking you then. Thank you very much. Thank you wholeheartedly. It would be a very big privilege for us to see Ercüment Bey here, but it was another privilege to have met you as well. I would also like to thank you very much, Koray Bey, because Ercüment Bey was my professor, and I had the chance to listen to him teach and lecture when I was at the Faculty of Medicine. But of course, even when I see the team photographs of him. I again feel very proud to be a student of him. Yesterday, we made a very good introduction to our symposium. In the first session, you turned our first session into a very pleasant one. Thank you very much for that. Thanks to your efforts, we're going to be even more successful. I'm an anesthesiologist. Our branch is different from yours, but the studies are showing that maybe we can only seem to be touching our babies only at the level of amniocentesis, but cellular and gene treatments will definitely take us to the original and the gist of the issue. I hope good things will happen. Thank you very much for all your efforts. Thank you.
Sorular varsa alabiliriz.
We can take if there are any questions.
Teşekkürler geldi.
There are thanks, participants thanking you for your presentation. Bahar Hanım's absence took a long time. Koray Bey, can I ask you something, by the way? Maybe I can ask something about mesenchymal stem cells efficacy on COVID-19. This is being discussed among my team frequently as well. Some centers say that they don't find the treatment efficacious anymore, whereas some other centers are saying that they can yield very positive results. What is your own opinion on this? In fact, cellular treatments are actually live treatments, as we call them. Therefore, they are dependent on production. They're not a standard pill treatment or injection treatment, where they're produced, how they're transferred, the application methods, etc., have an influence on our outcomes, that's for sure. Therefore, this is the reason why different results are being gained. If you're not doing a controlled study and if the center numbers are too many, the numbers and the outcomes will obviously be different. But not only in COVID, but also in other diseases, in the different types of ARDC, we see its effects. The mechanisms show that mesenchymal stem cells are working, but I think due to different application methods, we see those differences. Otherwise, in terms of mechanism, things are valid. For the steroids, tocilizumab, etc., used in COVID-19 has a long-term negative effect because but mesenchymal stem cells are actually not leading into an infection and has fewer adverse effects. But the production and the way of administration definitely changes things. Distinguished moderator, please warn us if we're making bad use of time. I want to ask some questions to Koray Bey since we have the time. A center is producing that, and also we're using the same administered drug in other peripheral centers, but you're saying that the administration routes might differ from one another. But at the same time, while asking for the material, dialogue with your center is a prerequisite, if I'm not mistaken. This is the reason why the administration time is important. I wonder whether you have a consensus about the administration time. No, this is not possible because all cellular treatments have a destiny. They're all used as the last resort, but they would definitely provide better results if they were used at an earlier stage. But as you said before, the patients come to us in really critical conditions, and we use these agents on those critically ill patients, unfortunately, and this decreases our chance. Thank you very much. I had an internet problem. Maybe my question's last part was not understood well. Let me repeat it. You have very successful therapies. I wonder what kind of plans and personal projects you have about the future of this treatment. Can you please talk about this by adding your own dreams into it as well? Because in medicine, we always talk about proven outcomes and proven results, but the purpose of our Congress is to do some brainstorming about the future. We see that we accept you as the experts of the future. So I wonder what kind of therapeutic method dreams you have for the future. Thank you very much. I have two dreams, I have to say. I'm a pediatric hematologist. We see that chemotherapists have very bad results on pediatric patients. CAR T cells have been revolutionary, although they still need some improvement. But if we start using those in the first line as a treatment, then things are going to be better. Long chemotherapy protocols will not be necessary. Adverse effects will be minimized. This is what I'm dreaming of. And I believe that this is going to take place in near future. Chemotherapy protocols will be out and cellular therapies will be in, I suppose. Do you think this is going to steal the show from chemotherapy because it is going to steal the show from oncology? Maybe it's going to be a difference in the way of administration, or are you trying to say that there will be nothing left in the name of oncology? No, oncology as a science will exist, but we're just going to get rid of chemotherapies because to the extent that we can decrease chemotherapies and we can get rid of the drugs harmful to our bodies, we're going to be better. Therefore, oncology's future will be without chemotherapy, I hope. My second dream is that when it comes to orphan diseases, this already started to happen, but individualized treatments can be devised these days. So in 10 days, diagnosis can be made, gene sequencing can be done, and anticellular oligonucleotides can be designed. Therefore, for orphan diseases at the pediatric periods, maybe we will be able to benefit from only animal trials without even without even having to wait for the phase 3 results of those trials. I think this is going to be another important future result. In our conclusion declaration, how can we transfer this last sentence that you have mentioned? Maybe these last dreams can take part in your declaration. Please send those to us in the written form so that we can include it in our final declaration. There is one question from Oya Birgen. How many cord blood banks are present in Turkey is the question. Cord blood banks, I don't know their number in Turkey, but cord blood's future is debatable. Some time ago, it was very popular, but in stem cell transplantation, we're not making use of cord blood anymore because other treatments are more on the foreground. So there is a decrease in their use. Cord blood banking is diminishing. But on the other hand, I can say one other thing on this. Maybe it's going to be a speculation. In a regenerative medicine's future, we're going to make use of cord blood cell in regenerative medicine. I think it will be used a lot in the future. Therefore, as new treatment options come, the number might increase, but right now the number of such centers is going down. Oya Emirgan, Professor Oya Emirgan is with us. I would like to say that I'm really proud to have her among us. Reproductive health has benefited from her as a leading professor. I see one question here. Mr. Moderator, can you allow me to read this? Cenap Ekinci is asking this question from Diyarbakır University. Very expensive and individualized gene therapies. I wonder whether everybody will have access to those treatments. This is what Koray Bey is asking. Maybe Ministry of Health as one of the sponsors and participants of our Congress would like to benefit from that information as well. Together with Oya Hanım's question, I would very much deliver this question to you. This is a very up-to-date discussion issue, and financial toxicity is in question. There isn't something called cellular toxicity only. There is financial toxicity in question as well. It's true, because the methods that we're using right now, the production methods that we're using today, unfortunately, is not bringing along a more cost-efficient methods. I think better methods to be more cost-efficient are still required. Yes, cellular treatments are very expensive, although commercial products of, for example, Chimera of Novartis is $475 in the United States, one session of it. It is being produced at a cost-efficient manner, but still it is very expensive. Milacent, the drug which I mentioned in my presentation, cannot be continued because it has to be administered to the patient continuously, and each practice, each administration is very costly. Therefore, it is something very debatable globally. But I think there is an idea which needs to be supported. I would like to call upon the Ministry of Health. As long as the productions taking place in Turkey are supported, and as long as we open up to the globe, we can produce those at a more cost-efficient manner. The costs are still high, but maybe we can find a solution.
Yakın zamanda Sağlık Bakanlığımızı biraz da zor duruma düşüren gen tedavileriyle ilgili, bebek hastalıklarıyla ilgili kampanyalar dahi yürütüldü. Bu anlamda
Solution to that. Koray Bey, of course, the ministry is working hard on this matter. And in terms of health tourism, Turkey has taken important steps. Do you think that Turkish scientists can carry out these treatments in a more cost-efficient manner here in Turkey? Do you think we have the potential to do that in Turkey? I definitely believe that wholeheartedly. As a person who has worked abroad and who has had the chance to observe things abroad, I can say that in terms of intellectual production, there is nothing missing in Turkey. In terms of education and training, there is nothing missing in Turkey. Infrastructure could be kind of problematic, but I believe that we're not very bad on that matter as well. If they are designed and targeted and planned, organized, good, I don't believe that there will be a treatment which we cannot administer. I think we should trust ourselves, believe in ourselves. I definitely believe positively on this. Everything can be done in Turkey. What we need is a proper planning and support. Yes, during the time of COVID-19, we've had many desperations and lack of opportunities. The ventilators that we produced in Turkey and the technological improvements are actually quite promising. As Koray Bey mentioned, maybe we're going to see new thrusts which are going to pave the path in front of us. Yes, so we've exceeded our time a great deal. Thank you very much. Would like to finish at this point. Let's pass on to the next speaker. Thank you very much.
sanırım biraz sonra Zafer Gören hocamız.
I guess Zafer Gören will be invited for the next.
Gören hocamız gelecek şimdi. O da kayıttan sunum yapacak. Şimdi onu ayarlamaya çalışıyoruz.
Present his speech. It will be a...
Hoca kongreye ulaştı. Kayıttan sunum yapacağını belirtti ama soru cevap kısımlarına telefonla ulaşmaya çalışacağını, teknik imkanlarını bunun için seferber edeceğini bahsetti. Zevkle dinliyoruz hocamız.
But he will be able to answer your questions later on. So now we'll have the presentation.
Hocam ses almıyoruz.
We cannot hear the speaker.
Ses gelmiyor mu?
Ekran paylaşırken sol altta Share Sound
Evet.
seçeneğini tıklarsanız.
Could you please share sound as well as the screen?
Çıkayım, tekrar geleyim. Evet, tekrar videoyu.
I will share the video once again.
Evet, share sound açık.
So I'm sharing both the screen and the sound.
Sanıyorum test paylaşımını ben yapamıyorum ama
I guess I cannot share the sound. How can we overcome this problem? I think it works now.
ses geliyor mu şu anda?
Can you hear the sound?
Hayır hocam, isterseniz ben paylaşayım.
No, let me share if you like. Okay.
Belki videonun başında ses olmayabilir.
Maybe at the beginning of the video there is no sound. Let me try once again, or I don't know.
Hocam isterseniz ben paylaşayım.
Is to understand how
Tamam.
therapeutic
Kapattım.
I just
Yok,
stop.
açıldıysa devam edebilirsiniz hocam.
If it is okay, you can continue. Did you have the sound? Yes.
Ses gelirse Kenancığım tekrar videoyu başa alabilirsiniz.
Yes. Can we have the? Okay.
Before I start my talk, I would like to thank the organizing committee for inviting me to this congress. Pharmacology is one of the newest disciplines in medicine. It is based on physiology and pharmacy, and it also dates back to the Middle Ages. Today, we will talk about the future of pharmacology. The first pharmacology department was set up in the 19th century in Germany. The reason why that department was set is to understand how therapeutic substances or poisons produce their effects. Drug design is a very important part of pharmacology, and it's an inventive process. It finds new medications based on the knowledge of a biological target. There should be a biological target, just like transport proteins, structural proteins, enzymes, or receptors. And most of these biological targets are protein in nature. But very rare occasions, we have certain drugs that doesn't have a biological target. For example, antacid agents. In the antacid agents, they simply neutralize the pH of the stomach. There is no biological target. So the phrase drug design is to some extent a misnomer. It is a ligand design, which means that we are trying to find out a molecule which fits to the biological target. It is the complementary molecule or the biomolecular target in terms of shape and the charge. And then after the ligand is synthesized, certain pharmacological characteristics are also examined. For example, bioavailability, metabolic half-life, side effects, maximum plasma concentration, or the time required to attain the maximum plasma concentration, toxic doses, and these should be calculated, examined, so that a safe and efficacious drug may be in the markets. So we have a quantitative structure and property relationship, QSPR, which uses the chemical, physical, and biological properties and predicts how a drug may be released and transportable. So these QSPR studies are very important studies. And we consider the chemical, biological, and physical properties, and we can find out how we can formulate that drug by using these studies. And computational techniques are very important. New models are being produced every day. So by taking these models into consideration, we can make new drugs. We can assess their pharmacokinetic effects by taking the physicochemical properties into account. So the drug design will become a multi-professional approach rather than multidisciplinary approach, because both engineers, pharmacists, and medical doctors are involved in the procedure. And then these models usually predict the composition of the formulation. So we can formulate a drug. We use certain excipient molecules. So all these studies require the activity of computers. So computers will become more and more important in drug design as well. The change in receptor number is also very important. Sometimes the receptors may be increased or decreased according to the signal. For example, if the signal is weak, the number of receptors are upregulated. If the signal is strong, the number of receptors may be decreased or downregulated. So the activity of drugs is very important. And we usually do not consider the activity of the drugs during drug design process. So upregulation and downregulation is a very critical thing in the forthcoming studies. Let me give you an example. For example, hypertension is a very critical disease, and we use renin-angiotensin system for treating hypertension. We have angiotensin converting enzyme inhibitors and angiotensin II receptor blockers. As these are the antagonists, so they cause the receptors to be blocked and the enzymes to be inhibited. So they increase the vasospastic tonus of the body. So it will make the patient vulnerable to vasospastic situations. So what we can think is we can synthesize certain vaccines against renin and angiotensin converting enzyme. But these studies were not very successful. However, angiotensin II or angiotensin II receptor vaccines will be much more effective in the near future. Monoclonal antibodies is also very important. We can synthesize monoclonal antibodies which can bind monospecifically to certain cells and proteins. And sometimes these monoclonal antibodies affect the T cell responses. So they can block the T cell responses by involving the T cell activities. And this is known as immune checkpoint therapy. So we synthesize so much monoclonal antibodies and treat many, many diseases. And the number of diseases which are treated by monoclonal antibodies will increase in the near future. And one of the important changes is the monoclonal antibodies can be used in treatment of drug abuse. For example, cocaine and nicotine, they can be treated by these drug abuse may be treated by monoclonal antibodies. For example, there is also a superiority in terms of nicotine treatment. In nicotine replacement therapy, we give nicotine to suppress the withdrawal symptoms. And then when we give monoclonal antibodies or vaccination, we not only inhibit the withdrawal symptoms, but in nicotine replacement therapy, we give nicotine itself, and this may have an additive effect on craving. So the monoclonal antibody treatment may be a better approach in treating nicotine replacement, in nicotine abuse. So in the 20th century, what we use is we used antibiotics to treat infections. However, due to evolution, we cannot find specific targets which are different from human biochemical machinery. So finding a new antibiotic will be very difficult. So we need vaccines. So again, vaccines will be very, very important, and many biological compounds will be the future drugs. In conclusion, biological compounds, vaccines, monoclonal antibodies will be used much than today. And vaccines will be used not only for preventing the infections, but it can also be used for treating drug abuse, cancer, and hypertension, and many other chronic diseases. I really want to thank you a lot for your patience. Thank you.
Hakikaten şahane bir sunumdu. Teşekkür ederim.
This was a great presentation. Thank you very much, Professor Zafer.
Acaba Q&A session'a katılma imkanı bulabildi mi? Kendisinin sesini, bağlantısını sağlayabilecek miyiz?
Hocam şu an aramızda Zafer Hoca, mikrofonu ve kamerasını açarsa.
Hello? Hello? Hello, Dr. Gören. Evet, mikrofonu sanırım sevgili hocamızın şu anda kapalı. Açma imkanı telefonundan bağlandığını tahmin ediyorum. Belki telefon application'ında bir sorun olabilir. Ben bayıldım. Çok şahane bir sunum. Özellikle günümüz şartlarında anladığım kadarıyla söyleyeyim. Farmakoloji bölümü şu anda kullandığı kimyasal ilaçlardan ziyade biodrugs dediğimiz, yani biyolojik silahlarla bir devrim yaratma hazırlığında. Özellikle hocamızın sunumunda benim çok dikkatimi çeken bir şey, ilaçlardan çok belki aşılarla tedavilerin geleceği olduğunu söz etti. Şu andaki pandemide yaşadığımız bu sıkıntıları belki de ileride tekrarları olabileceğini, ama geniş kapsamlı bir biyolojik aşılama sistemiyle, bir programıyla belki gelecekte bu tür sosyal ve finansal problemlerle, sağlık problemleriyle karşılaşmayacağımızı sordu. Ben kendisi eğer canlı yayında olsaydı, kendisine bu konuda farmakolojinin devrimi açısından nelere ihtiyaç duyduklarını ve hem ülkeler açısından yalnızca bilim değil, finansal düzeyde ihtiyaçlarını ve programlarını yardım etmek için bakanlık düzeyinde ya da işte finansal düzeyde nelere ihtiyaç duyacağını özellikle sormak isterdim. Çünkü fikirler şahane ve ileride ihtiyaç duyacağımız şeyleri şimdiden hazırlamak adına çok güzel paylaşımlarda bulundular. Burada bir soru var. Sevgili moderatörüm, son soruyu siz okumak ister misiniz? Şeyle bahsetmişler, hidroksiklorokin karaciğer enzimlerinde artış yapabiliyor ve dikkat ediliyor mu bu konuda diye ülkemizde, tabii ülkemizde benim bildiğim kadarıyla bakanlık bu konudaki article'ları çok yakından takip ediyor, fakat Amerika'nın böyle bir başkanıyla ilgili bir propagandası olmuştu bu ilaçla ilgili. Tabii siyasetçilerin böyle sağlık demeçleriyle hareket etmesi bilimsel bir görüş olmadığı için çok hoş karşılanmadı Amerika'da. Ama onun modası, şimdi biz o kadar hani denize düşen yılana sarılır gibi böyle bir ilaç duyduğumuzda da hemen bilinmezlikler böyle yanlış sonuçlara yol açıyor. Uzun vadede karaciğer problemi yaşandığını hekim olarak ben de düşünüyorum. Sanırım Zafer hocamız bağlanmadı. Başka sorusu olan var mı sevgili moderatörlerimiz? Katkınız var mı
Do you
konuyla
have
ilgili?
any more questions or comments? Well, it's not a contribution, but just as we said at the end of the previous speech, in pharmacology, there are so many promising innovations. And just like in the vaccination, everybody is getting affected from one another. And we have seen that in Samsung very recently. There's a pharmacologist in Samsung has been supported for developing a monoclonal antibody. So I'm sure that you are supporting that specialist. So they are very lucky to have you. Yes, we are in close contact with him. And if we have the opportunity to provide his conditions, then he will work with us. But of course, if not, he will find the appropriate partner. So hopefully that study is going to take place. By the way, let me ask you about our local vaccine. There are very important and promising developments about that. So do you have any news about the local vaccine? Well, there was an expectation that it would be ready in April or May, but now it is said that August or September. Hopefully it will be developed, because without vaccination, we cannot overcome this pandemic. As far as I understand, we have to be very careful, and we have to pay due diligence, just like every scientist, without causing any damage, because we know the problems with AstraZeneca vaccine, and most probably during the experimental phase, the Turkish government is taking it more slowly. Well, we have to be quite cautious about this vaccine, because the reaction, treatment, at the beginning, there was no treatment. And now we have the vaccines, and sometimes when you get the reactions, and when people see some reactions, then people do not believe in the effect of that. So we have to be very cautious. Thank you very much for your moderatorship.